Some of the obstacles I anticipate for Mary reaching her goals include the fact she lives alone with 5 steps required to enter her home, and her bathroom and bedroom being on the second floor, which requires 12 steps. Another obstacle would be the edema and risk of skin breakdown. Difficulties for me as a therapist when working with Mary reach her goal include Mary's unwillingness to utilize adaptive equipment, her fear of weight bearing, and her reluctance to work with nursing assistants. Some posterolateral hip precautions include that she should not bend her hip more than 90 degrees. I have explained that to her, such as bending forward while sitting. She can't bend forward while she sits. Another important precaution is for Mary to not cross her legs. And lastly, she should be careful about positioning her hip inwards, so don't point her toes inward. Instead, she needs to keep her toes and knees straight. Devices that will be needed for Mary to adhere to her total hip precautions while toileting and sleeping. For toileting, she would want to use a raised toilet seat to help prevent her hip from flexing past 90 degrees. And while sleeping, she would want to use pillows or another device to support her legs to prevent herself from crossing her leg during her sleep. I'd have Mary perform her ADLs with adaptive equipment, such as a long-handled spongy dressing stick, and in the event that she refuses to use adaptive equipment, I'd want her to perform her ADLs within the presence of a nurse assistant to ensure she follows proper precautions and doesn't risk injury. I anticipate that her lower body dressing and toileting will be the most difficult of her ADL routine to accomplish, again because of her fear of weight bearing and her not wanting to use that equipment. And the use of a dressing stick and nurse toilet seat would be the most beneficial way to be able to adapt that ADL routine and maximize independence. But again, if she refuses to use it, we're going to have to teach her compensatory techniques. As far as her ability to prepare a meal, I believe she would be able to, due to her cognitive ability still being intact, as well as her range of motion and strength being within functional limits on her right upper extremity and still fair on her left upper extremity, so with some slight modifications. I believe she'd be able to prepare it, as well as her previous independence with ADLs prior to hospitalization, provides me confidence she will be able to prepare a meal. Mary's social goals and leisure goals. She enjoyed reading to children in the library, and she could potentially still read stories to children in the hospital unit to help fulfill this need, or we could have her video called into her local library where she could read to the students while still in the unit. Mary also enjoyed speaking with her sister and visiting her. This could be accomplished by their visitation from her sister to the unit where Mary is located, or setting up video calls so they can still talk to each other. If Mary refuses to use the adaptive equipment, I would help instruct her on potential compensatory techniques to complete the ADLs instead. And I would also use a rehabilitative technique to help try and regain her strength in her lower extremities so that she can complete those ADLs, as well as implement CBT to help address her fear of weight bearing, so we can try to tackle that as well. I'd ask her questions about her home, such as her shower, is it a walk-in shower or a tub, and if it is a tub, how high the walls are, to try and figure out how difficult it would be for her to bathe. I'd also ask about potential fall risks in her home, such as does she have any loose rugs around that she could possibly slip on. And I'd ask if she has railings along the stairs into her home, as well as leading up into her bedroom, so that she would be able to walk and have something to support her. What approach might I take to reintroduce adaptive equipment? I'd explain to her how the adaptive equipment is a means of providing her the independence she desperately seeks, and that without it, it'd be much more difficult and take longer for her to reach that independence, and quickly returning was one of her main motivators. What would I do to address her neuromuscular status? I don't currently believe she has any neuromuscular deficiencies because she didn't appear to have any nerve issues. Mary says that she'll participate in only one group unit. I would recommend a safety awareness group, as with the posterolateral hip procedure, she's going to have a lot of precautions that, if are not followed, could potentially cause injury, and obviously would not be good, and we don't want any further complications. So moving on, psychosocial. How do I believe she's dealing with her transitional care unit placement? I think she's somewhat struggling in her placement, mainly due to her attempting to distract herself from her changing health status by constantly discussing her social life and troubles with the library instead of the health status with the workers. She also attempts to ignore her changing health status by closing her eyes or looking away from the incision site and refusing to talk about surgery with the workers as well as the nurse assistants. What feelings do I feel she might have regarding her recent surgery? Why? I believe she might be feeling some shame and disappointment in herself for requiring the surgery due to her reluctance to talk about the surgery or look at her incision, as well as refusing to utilize adaptive equipment or gadgets. I also assume due to her trying to cancel the surgery before and saying she could go without it. How can I prevent myself from responding negatively to Mary? I'll prevent myself from responding negatively by being mindful of her circumstances and recognizing the difficult time she's going through, which may cause her to be combative or uncooperative. She lives alone and is losing much of her independence, which is going to be hard for anyone to deal with and can lead to some negative behaviors. What might some psychological concerns be? Potential psychological concerns for Mary are depression following her discharge from the transitional care unit. What educational information is essential for Mary and why? Information on hip precautions following the total hip arthroplasty are essential to prevent injury and complications. And other important information for her includes the importance of mobility and range of motion to prevent stuff like contractures, edema, as well as trying to regain that functional status of her. I enter Mary's room in the morning and she's got another assistant to her self-care. What might Sarah do? I'd educate her on the importance of performing your tasks yourself as much as possible so that she can maintain her current skill levels and help rebuild towards that independence and work towards her goals. Now explain while it's fine for the nursing assistant to provide assistance during completion. She should contribute as much as possible. I enter Mary's room and find that she has already partly finished with Mary's self-care. What would my reaction be at the time and why? I remain calm and politely inform Mary that I'd like her to contribute to the remainder of ADLs and remind her again of the importance of her participation in the ADL care routine to again work on rebuilding that strength. If I overhear Mary talking to me about therapists at the facility, I would either two things, either do nothing about this situation if I don't believe it's serious, or discuss with Mary why adaptive equipment is important in improving her ADL independence and explain that they are common, a lot of people use them, they're easy to adjust to using and really help her be able to reach her goals faster. How it makes me feel to know she is a notified licensed helper. I would try to remain unhurt as I know she is suffering through a difficult time. And as a member of the healthcare team, pushing her to her limits in order to recover, because sometimes people will take that in a negative manner because people don't like being pushed to work on something they don't want to. In the OT kitchen, while Mary is practicing making tea, I know she's not putting weight on her left lower extremity. I would explain to her that she does not use her left leg. She can suffer complications down the line, such as atrophy from disease, perhaps edema, like worsening of her edema, contractures, etc. And I want to explain how it can lead to a vicious cycle that would prevent her from being able to use her left leg again. While transferring to the commode, she cries out in pain. She says her left hip. I would cease the transfer immediately and assess her for potential injuries, as well as inform the nursing staff and write it down as an incident report. How I document it, I would again talk to residents as report as soon as possible and objectively as possible. I would document the incident in her daily note. For discharge planning, I would begin discharge planning right during the initial evaluation as I start hearing her goals and see her limitations. What level of ability would Mary need to return home? I believe she would need to be able to complete her ADL safely, as well as be able to go up and down the stairs required in her home without being at risk of fall. What role would her sister play in the discharge process? What role would Mary play? Mary's sister could potentially allow for Mary to be discharged earlier by providing assistance with Mary's ADLs in her home that Mary is unable to perform independently yet. Mary is the most crucial aspect of the discharge process, as her ability to bear weight on her lower leg and not be at risk of a fall is going to be one of the primary factors in my ability to discharge her. She will also need to demonstrate competence and understanding of the precautions to prevent injury. How might Mary continue to work towards her goals once she leaves the unit? She would continue to work toward her goals through possibly telehealth programs or home exercise programs, or even OT home health services in order to help her keep receiving treatment and working along those goals. Would I recommend her OT for home at Mary? Why not? I would recommend continued OT for home for her, as she has been not wanting to weight bear on her lower left leg. So I would want to try to get her to the point where she is able to do that comfortably, as well as complete her ADLs with full independence, or possibly modified independence if she needs to use adaptive equipment. If I did recommend OT at home, would I still do it if OT told me she didn't want to do it, or if Mary told me she didn't want to do it? If she did refuse OT services, I would potentially try recommending telehealth services in case she doesn't want anyone left to enter her home. Or I would recommend some various home exercise programs for her to complete that she could then come into the clinic for checkups later. If I didn't recommend her to home, what would I want her to have in place? Again, like I mentioned earlier, the telehealth services, or perhaps an OT only eval to determine her ability safely, and if home exercise program is all she needs. Moving along, occupational profile for Mary. She's 72 years old. She's adult, geriatric, developmental stage. She didn't have any cognitive issues. She had a total hip arthroplasty through a posterolateral incision. Precautions for her include hip flexion up past 90 degrees, leg crossing, and hip internal rotation. Some of her other medical and behavioral history is osteoarthritis, hypertension, and previous UTIs, which again, if she's having trouble toileting, can cause a recurrence of those. She is currently seeking services as she wishes to return home to her home setting independently, walk without a cane, and get up and down her stairs without pain. What I know about her is that the client lives on her own in her home that has 5 steps to enter and 12 steps to go through the second floor, which has her bedroom and bathroom. Her day involves being a volunteer at a local library where she reads stories for children. She also enjoys playing cribbage with friends once per week for leisure. Prior to her surgery, the client was independent in all her ADLs. And then currently post-surgery, she requires assistance with lower body dressing, bed mobility, transfers, lower body bathing. She attempts to ignore her surgery as she looks away from the incision site and refuses to discuss surgery with assistants. Her goals include returning to her home, being able to walk without a cane, go up and down stairs, and live independently. One of her major motivators for the client's return is again that local library because she wishes to continue to read stories for the children. Moving on to the last part, her OT eval. I noticed that she's independent with her feeding and eating, her upper body grooming, so she was fine with upper body dressing and bathing. She was completely independent. She required total assistance on her lower body dressing and lower body bathing because she was unable to perform them because of her precautions. Toileting and bowel movements, I was unable to assess because they did not mention it in the paper, as well as personal device management. Her bed mobility, they mentioned she was in moderate assistance, and I noted she braced herself for pain the whole time during it. And then for her transfers, she was max assist, and they noted that she should have been able to perform with a stand pivot, but instead she performed with a squat pivot. She was unable to assess her tub to shower transfers, they did not mention it. And as well as her assistive device for mobility management, she used a standard walker and also required max assistance under that. Comments I noted were that she demonstrated unwillingness for adaptive equipment. Moving on beyond disability, play skills are not applicable to her as geriatric. The skills normally refer for children. Her leisure skills, though, would have been fine and intact for playing privilege. Education participation, she's not currently in any education programs. Sensory integration, there were no deficits observed to her for sensory issues. Looking at AROM and PROM, her shoulder has impaired movement with only 2/3 of normal movement, and the manual muscle testing was impaired with a fair minus, an F plus. Fair plus is required for within functional limits, and insensation was within functional limits for everything. She had no edema anywhere except for her left lower extremity. Everything else was fine. Again, upper body, elbow, forearm, and wrists were all within functional limits. And going down to her digits, her right hand was completely within functional limits, but her left hand had impaired AROM and PROM because she had pain when making her fist, and impaired manual muscle testing, as she again had an F minus or F when F plus is required in upper extremity for functional limits. Grip strength was unable to assess because they did not mention it. Muscle tone was all within functional limits. Posture alignment within functional limits. Coordination was all normal within functional limits. Motor playing all normal. Pain, no check pain with her left extremity. Moving down again, comments refused to look at her incision, slight edema in the lower extremity. Her balance while sitting was fine, but standing she's going to need assistance again due to her inability to place any weight on her lower left leg. Moving down, for vision perception, she did require glasses. Her hearing and communication were all within functional limits. Cognition was within functional limits, and she was orientated to everything to gain no cognitive delays. And that's about everything on Mary.